You're tuned in to the STED Talk, Spine Technology Education, and the D, as you know, is pluripotential discussion, debate, discourse, discovery on various subjects that are contentious in our specialty. And I welcome you to the wonderful facilities at SSF, and I want to recognize Ben and Alexis who are here. Our AV director and our overall director are both here to bring this program to you around the world. So thank you for your interest today. We have a very cool topic with an even cooler presenter, Dr. Elias. He is, and I'll introduce him more in detail later. He's an assistant professor of neurosurgery at the UT Southwestern, Dallas, Texas, so a complete conflict of interest on mine. And he wanted to talk about evolution of spondylolisthesis. And as always, our wonderful fellows are not getting ready for the holiday, but they're actually working. And they selected actually a total of 5 cases presented by 4 fellows. One of them will start with 2 cases, and that's the infamous D3, Dr. David Davis III. And he's coming up and he's prepared them. I'm gonna fold up this laptop. And thank you.
All right. Case 1. This is approximately 75-year-old female who's very physically active. She has a history of claudication, radiculopathy, and previous laminotomy by a previous surgeon. And she's undergone extensive non-operative care. She's got no neurological deficits. And you can see that she's got a grade 2 spondylolisthesis seen here on the MRI. All right, so we'll pause here. Dr. Elias, do you have any thoughts initially about this case or any other question information on what you would go for?
Can you tell me again what was the presentation of this lady?
I'm sorry, could you repeat that question one time? The presentation, yes. So she's a 75-year-old, very physically active female. She's had previous laminotomies, and she's got this grade 2 spondy noted on the x-rays here. Her symptoms are mostly claudicatory and radiculopathic.
So this is a common problem. A female, extremely fit, very world savvy, and she has an evident degenerative scoliosis. She did not know of this. She was never treated for it. She can't walk anymore. Highly functional. She's retired with her husband. She wants to travel the world, and she just can't walk anymore. She has a pretty high-grade stenosis at L4-5. She has a degenerative spondylolisthesis at L4-5. I know we're talking about isthmic spondylolisthesis today. And what do? She has this back pain, leg pain, buttock pain, but the main thing that bothers her is her buttock pain, leg pain that prevents her from walking. And she's tried and tried. Thoughts?
Can I have the pictures again?
Yes, sir.
All right.
Here's her standing x-rays.
Yeah.
Single slices of the CT scan.
Yeah.
And as I just give you some pertinent slices of the MRI. I'll pause here. You can see her degenerative spondy.
All right.
And then on the axials, you can see she's pretty tight.
And the previous lamies were for, you know why she had the previous lamies?
Similar symptoms at the same level, at 4-5.
And it really worked.
It worked or it did not work?
It did not work, really.
All right.
She has a tight stenosis at 4-5 still.
All right. She's 75. She's highly active.
Very active.
Yeah, I know
Very
that
active person.
very active person. I know that she has some scoliosis, but I would discuss with her only like 1-level fusion. I would tell her risks and benefits of not going for a big segment over here. I would
if you do a fusion, Elias, and thank you so much for being here today. It's very cool to see you. Would you do a reduction of the deformity? I mean, she's slipped a little bit. She's rotatorily slipped. She has a coronal and a sagittal imbalance. What would you do specifically if you do a single level fusion?
I would go from the back. You can do a TLIF over here, and I would reduce, but not all the way like full reduction.
Why would you not fuse it all the way?
I mean, you said that she's highly, very active
Yeah.
patient, and she wants to travel and so on. So I would choose only the level that's hurting her with the severe stenosis, and tell her whenever you're like doing worse, you can come back later for a longer fusion.
Yeah. Is there any role for a revision decompression, just cleaning her up one more time?
I did not see the parts here. Does she have like intact parts?
She has an intact pars, right?
She does have an intact pars. This is a degenerative spondy. It would be great if I had included a CT scan of that. We can maybe catch it on the MRI here. But it is, if you take my word for it, it's intact with a degenerative spondy.
All right. And so all right. So there are no movements, right, on FlexX.
We don't actually have a specific FlexX film. We just got our standing scolies.
All right.
A reasonable point. We did not assume any big motion. She does not have fluid in her facet joints, but you're right, Elias. This is a indirect measure of stability. Pretty significant stenosis there, just crowded over. Clearly, there's some instability, but not dramatic, and she's obviously slipped. So decompression alone, not a factor.
I mean, we can offer her decompression alone. I would also compare if we have previous CTs or X-rays to see if she slipped forward from before she had the lamis. I would still fuse like one level over here.
Okay. So we had extensive talks to her. Dave, do you want to take us forward?
Yes. So a lot of discussion. And we ended up doing a revision decompression with a Coflex.
Okay.
So this patient did exceedingly well. We saw her back in clinic this week, and she's extremely happy. This is a really great case because I think that it would not be crazy for somebody to see 75 degenerative scoliosis and think that this person needed a T10 to pelvis with the apex at L2. But it just goes to show that for a patient-specific treatment plan, we can have a lot of success with a smaller surgery.
This is, again, a temporary success so far. I tell patients there's a 15% risk of failure by 2 years. That's based on the MAUD database and a 5-year plus outcome study. The first 2 years are the critical ones. It was my thought, I don't know what your experience is there, Elias, if we did a one-level fusion on her, given where you see the 3-4 vertebra, this would highly likely fall apart. And so we're then starting to eat our way up and down the spine, and she's a postmenopausal white female, so we're right now talking about a T9 to pelvis fusion. And she and her husband they're very intelligent people. They were adamantly opposed to that, and it would have conflicted with their summer and fall travel schedule. So they came to clinic on their way to SeaTac Airport to fly to Vienna. And she felt highly encouraged. She came with a backpack on her back, so they were ready for travel. But we could have not had that kind of a rebound with a T9 to pelvis fusion. But any thoughts on this? Have you used this kind of an interlaminar stabilizing device?
I have not. I've only used them with you when I did the fellowship. I have not since used any of those. I mean, I know eventually she will fail. That's why I said initially to do like only one level fusion and not only decompression to finish whatever she is going to do for her travels and plans, because eventually she will come back. And I'm not sure how much Coflex will also benefit her on the long term.
I fully agree with the board. This is definitely an outlier case. We're very careful to expose our pars on both sides so we could preserve the pars. This has been a device that I've learned a lot more over the time. We've refined some of the instruments, but it's still, I mean, I am very appreciative of the fact that we can avoid a fusion. And the bounce back is significant. For me, the learning point is a lot of patients are just really very heavily impaired by back pain, which we think of mechanical, but it's actually neurologic back pain. And as you may remember, I really like trying to sort out what is a neurologic type of a back pain from a mechanical back pain. To me, it seemed the priority by vast majority was neurogenic, but difficult thing. Dave, what have you seen in terms of differentiating neurogenic back pain from or claudicatory back pain from mechanical back pain. Any tips and tricks?
I mean, this is something that I'm really trying to hone in on at the end of my fellowship. I know I've talked about it a lot with my future partner and current co-fellow. So it's difficult to distinguish neurogenic versus axial and degenerative back pain. But I think that our standard pain with extension and rotation tends to make me think that it's facetogenic, whereas purely extension pain and obviously the radiating symptoms will tip me off towards neurogenic. Then obviously pain worse with flexion in the absence of like a clear foraminal stenosis, I think discogenic, but I think there's a role for injections in the facet joints to help elucidate that. And honestly, I hope that the last month of my fellowship, I really hone in on it more. So always open to tips from you and Dr. Elias.
To be continued, though, again, for now, we had a dramatic pain relief. She's over 3 months out now.
Yes, sir.
She's very, very happy, and we'll see. But this is, again, may just be a patchwork, a Band-Aid. Maybe it'll help her for a couple of years. She clearly did not want a T9 to pelvis fusion.
No,
I
don't think I
understand
would
you
either.
prepared a second case.
Yes, case number 2. It's approximately an 80-year-old female who has many medical comorbidities. She's very pleasant, got a history of a previous laminectomy with a grade 2 isthmic spondylolisthesis at, as you can see here at 4.5, with the pars defected. She is fully neurologically intact. A neurological exam, as I stated, she's neurologically intact, and we do have flexion and extension films which show a stable grade 2 spondy. You got the MRI here with selected CT scans where you can visualize our pars as well as the disc degeneration. And so again, we'll pause at this point with some similarities, some differences, and I'm curious what your thoughts were, and let Dr. Chapman chime in as well.
Just quickly, we checked her bone density, and we
Yes.
checked it with DEXA scan in the non-spine region. We checked it with Hounsfield units on
Yes.
CT.
She's got so on her femoral neck, which is our usual standard, she was osteopenic, but on her distal radius DEXA, she was osteoporotic.
So we did refer her to the pain clinic, and she did have an old intrathecal pump catheter sitting in there, reflective of how bad her pain was. She did not know that she had that L1 compression fracture, which looks totally healed.
Yes.
So Elias, so here we have a situation, L4-5, severe foraminal stenosis. This is an old isthmic spondylolisthesis. She has a significant central stenosis, which is unusual for isthmic spondies. She has an old intrathecal catheter running around the control unit. The pump reservoir is gone, but this is an indwelling catheter, and she basically can't walk anymore. Any thoughts of doing an anterior or a lateral or anterolateral surgery are pretty out of question.
Yep.
Because she's had abdominal surgery, so there's a lot of clips going on.
Yeah. So she has also, so this lady, she has pars fracture, right?
Yeah, there's no pars.
So I would definitely fuse this lady. Anterior would be an option if she didn't have abdominal surgeries. I'm not sure what she had before. There is like more bone on bone over here. There are no disc space. She's 80. We can do like posterolateral fusion with like only screws. I'm not sure if there is a need for a cage over here.
So in situ fusion, no deformity reduction?
I mean, this is only like grade 2, so we can decompress and do in situ fusion. Or if you want to be aggressive, since she has, her bone quality is not that bad. So, I mean, we can still put a cage if we want to. She's already 80-year-old.
And it would have been useful to you as well if I provided the fact that she does have claudicatory symptoms, and if I had included the axial MRI, she is stenotic at that level. Does that change what you would say about whether you use a cage or not?
It would not for me, because I will decompress regardless. So okay. I can do like Gillamy, and once you expose UT bilateral pars fracture, it will be moving. We can do like directly in situ fusion, or like put screws in, get out, or put a cage, have more blood loss, more OR time. It's only one level, so I think both ways it will work, with or without.
Awesome. Thanks for your insight.
All
Appreciate
right.
it.
So
going forward, what we did here was we did a wide decompression with a 3-column intradiscal osteotomy and a bilateral cage with reduction. This patient is still inpatient. This is very acute. She's doing very well. Had a really nice result, I think. So,
Do you have the CT scan?
no, I don't think I got
Yeah, we
one.
basically did a full.
Oh, yeah, I do.
Yeah, we did a full decompression at that one level only. We removed the unstable porous bone segment. We did a full neurolysis of the exiting roots, and we then did an intradiscal osteotomy and pulled the spine back. You can see the long screws, so we have a good foundation. And we used bilateral cages and did an anatomic reduction. The thinking being, it's not being cute, but we wanted to realign the spine as anatomically as possible to take the pressure off her upper spine. But she had no dural tear, and she's actually done quite well.
Yeah, she's done great.
So I don't have long-term follow-up on her either, but we thought that we'd show you those two older patients with different problems, but similar problems. Any thoughts on reducing a patient with an older skeleton to have an improved alignment?
Not really. I think you can reduce them. Like you did, like an excellent job over here. Just the age is a factor for me. I would like tell this patient, I know that you have a slip, but you were 80. I wouldn't like try to put cages or to reduce over here. I would do like less, just to try to avoid any complications. But I mean, results here are excellent. So reduction works with an 80-year-old.
Yeah, the details, again, very accurate. Screw placement has to be bicortical and near bicortical so that they don't cantilever out. You can't poke around with multiple screws. And the incision length is like 4 finger breadths long. So although it is, quote, open, it's not that invasive. And she didn't lose much blood either, right?
No, she did great. I mean, we lost maybe 600 of blood.
Yeah.
I would have to look at the op note, but something
I
like
thought
that.
it was not, she did not need blood transfusions. We left that intrathecal catheter in. We were prepared to take it out, but
Yeah.
the door was fully intact and I saw no reason to take it out. Any reason to take it out from your end, Elias?
If it's not in my field, I wouldn't take it out. If it's not in the surgical field, I would not take it out.
All right. Well, thank you. Thank you, D3.
Yeah, thank you.
And we follow him up with Dr. Anderson, who's going to take a different view of spondylolisthesis repairs. Thank you, Brian.
Yeah.
He's working with Dr. Amir Abdul-Jabbar right now in Issaquah. And so he's come over this morning to present this case.
Yeah, thank you. So this is a patient that we recently took care of last year, a 68-year-old male. He has 7 weeks of progressive low back pain. He has a foot drop. He has difficulty ambulating. He's using a 4-wheeled walker this time. And this happened acutely because approximately 2 months ago, he underwent an L5-S1 standalone ALIF. And this was due to a grade 1 spondy with degenerative disc disease and significant low back pain. This was done at an outside hospital, and at the time, the surgeon was considering just doing a standalone if the patient did well, and he did well for several weeks. However, about 5 weeks after that surgery, the patient had an acute onset, non-traumatic onset of recurrent low back pain, and imaging was obtained at that time, and there was some subsidence thought by the surgeon of his instrumentation. And so he was taken back for posterior fixation. I'll have x-rays for you here in a second. That was completed and the patient's pain did not get better. He has intact bowel and bladder on exam, but he has an obvious foot drop on the left, weakness with the ZHL, a left L5 radic. His BMI is approaching morbid obesity. He does have diabetes, hypertension, hyperlipidemia. These are his preoperative flexion and extension x-rays that we were able to obtain. And you can see dynamic grade 1 spondylolisthesis at L5-S1 with disc height loss. And this is a CT scan that was also obtained about that time. And you can see that there's reduction of his spondylolisthesis to some degree when he's lying supine. And then he has somewhat of a isthmic pars fracture. on that left side. Here is an AP right after the ALIF was performed. And then here's a lateral on the left side at the time of surgery. And then you can see on the right side of the screen an X-ray, another lateral that was taken approximately 5 to 7 weeks later, showing by the red arrows he has a sacral promontory fracture with, you can see, obvious loose caudal screw there with subsidence of his cage. So the patient, like I said, he was taken back and he had unilateral posterior fixation placed. And it was done unilaterally with cortical trajectory. You can see the screws are loose right there. And it was done unilaterally because at the time of surgery, the surgeon discovered what you can see there is a pars fracture on the right side. And instrumentation of the right side, L5S1, through those cortical tracts or any other tract was aborted at the time. So in summary, this is a gentleman, 68. He's 2 months from an L5S1 ALIF, and then he had the sacral promontory fracture, and now he's 3 weeks from a unilateral 5-1 instrumentation using cortical screw trajectories, and now we know that he has a right L5 pedicle fracture. He still has a low back pain, foot drop, and gait intolerance.
So Elias, so this is a nice case. Can you go back a little bit to the initial film? So one thing I want to say for isthmic spondylosis, I think we can all agree patient optimization is necessary. These are usually elective conditions. And if you have a patient who is obese, uses nicotine, has dysregulated diabetes, these are all modifiable comorbidities. And they should be optimized prior to surgery. I think you'd agree with that, right? Nicotine cessation, diabetes optimization, some weight reduction. I've noticed more and more patients, and this is a paradigm shift, at least here in the Pacific Northwest, sorry, where surgeons think that it's, quote, less invasive to go in from the front first, put a graft in, a spacer, and then come in from the back with, quote, less invasive, I'm being cynical here, screws being placed. So what do you think of this in terms of this kind of a fixation approach of going front and back?
I've seen patients like this. I've seen patients who had ALIF and unilateral posterior fixation as a second stage later on. I do not do this type of cases. I was not trained to do it this way. I think this is more of a patching than dealing with the real problem. If someone is going to do an ALIF, I think it's better to fuse properly from the back and not to do just standalone. It wouldn't take much more time, and it's an extra like safety for the patient, especially like what happened with this guy with subsidence. Now, I'm not sure if this patient, do they have bone density before they did this surgery or no? And I'm not sure how they did the ALIF, like what went wrong.
Outside hospital, he was treated in an outside hospital, so he had an incomplete workup. And again, there was no prehab done, so nicotine cessation, not diabetes control, not significant belly weight, not
You can
reduced.
see the Hounsfield units are around 100 on the CT scan for the lumbar spine.
Very perceptive. So despite being male, he has poor Hounsfield units. He probably has low testosterone. He's also on opiates, I think. He was not detoxed, I thought.
You may be, I can't recall.
Yeah, I don't think they took time to well prepare this patient before the surgery. And eventually they got this bad result. So I think this was expected eventually. Now for the foot drop, he presented with how much time since he had foot drop? Like,
Uncertain as to whether the patient had a foot drop prior to the index surgery, but he did have a foot drop when we examined him in our clinic, which was 2 months after the index surgery.
2 months, you said?
Correct.
All right. I mean, with the 2-month foot drop, I would start telling the patient that he might not regain. There is a possibility of not regaining his strength. And I don't know, Dr. Chapman, I think I would like optimize him now instead of having another failed surgery. I don't know. What do you think about like optimizing before reoperating?
I always love optimizing, but now we're faced with the problem of he has a sacral fracture. He has a coronal plane sacral fracture, and that cage is migrating down. And so for me, the decision point there was one of a greater acuity. That means we either stabilize this man now, or that graft is going to go, that cage is going to go into the lesser pelvis, and this will be a extremely messy revision exposure in a man with a very sizable abdomen. So for me, this changed from a elective condition to a sacral fracture, a complex iatrogenic sacral fracture. I don't know, Brian, you've seen the patient before. What are your thoughts? Would you have liked to go back into that retroperitoneum?
No, not at all. And the patient was quite large, and he was mostly truncal with his weight. So this gentleman needed a robust 360 fusion, and I don't see what we could have done to benefit him from the front. Certainly, just the front.
So why don't we go ahead then?
Yeah.
So we decided to move ahead.
So we proceeded with surgery within a week or two. You can see what we did here on the right side of the screen, but simply put, we took out the cortical screws, instrumentation from the backside, and then we re-instrumented L5-S1 using pedicular tracks, and we also instrumented down to the pelvis. We used 7.5 and 8.5 screws, bicortical fixation, especially at S1. And the surgery was otherwise uncomplicated and went pretty smoothly. These are the fluoroscopic images that were obtained at the time of surgery. And unfortunately, these are the last images that were available in our PAC system for me to present, but the patient was seen just a month or two ago, so it puts him about 3-4 months out of surgery. He says his low back pain's resolved. He's walking now without the assistance of any ambulatory aid, and he's also lost about 10 pounds. So he's much improved from this surgery.
So his foot drop is better now?
I thought so, yeah.
Okay.
Yeah, he says he's walking. I think he has trekking poles, my favorite mobility aid. He's actually changed his life around a little bit. He lives alone, but he's taking better care of himself. So it seems. But we went for posterior only, hoping that there's enough anterior healing potential, despite this being a plastic cage, which does not have inherent healing potential at all, and did an extensive posterolateral fusion, and hope that our hardware will hold posteriorly to afford lumbopelvic fusion.
Do you ever try to remove the cage from the front, or you just leave it?
I hope not. Again, the whole hope is that we've given him a stable posterior scaffolding and get that to heal. And the key thing is, if, Brian, you go back a little bit, he had that bizarre pedicle fracture that I think occurred when a percutaneous screw fixation attempt was undertaken by the previous surgeon. If you can scroll through the axials and highlight it. And the previous surgeon thought we'd have to go to L4, but these are cortical screws. There's another screw type that I really don't understand. It's nice to have it as an option in your armamentarium, but I do not understand the merit of it. But something happened during the previous surgery in an outside facility where the pedicle sheared off, and our postoperative CT scan shows we're actually able to go across that with a standard pedicle screw. So. Yeah. Don't listen to the advertisement hype of some companies that try to promote cortical screws as somehow being superior. They have a role. It's nice to have an armamentarium, but I just don't understand how this can be the go-to fixation, especially in a mechanically highly unstable spine. So we were able to limit it to one level and one level only.
Excellent.
But I don't want to go back anteriorly unless I absolutely have to say. I'd rather revise them posteriorly and then go back anteriorly. But after seeing that abdomen, and the previous exposure was not atraumatic, that was a pretty sizable incision. So this would not be a benign exploration of the retroperitoneum.
Yeah.
Yeah. Do you put them in braces or no?
Do what?
Do you use the brace, post-op brace?
There's no brace on this man. He's large.
Yeah.
This is a large man. A brace would serve as a kind of a abdominal restraint mechanism, paniculus corset, but not a mechanical support for the spine.
All right.
All right, thank you, Brian.
Yeah.
And we have Dr. Cliff Pierre standing on deck. Thank you very much for this. And he has another slant on a spondylolisthesis. Thank you, Elias, for being here this morning. So good to see you again.
Again, good morning, Dr. Elias. Again, good seeing you. Also like to take a moment to briefly welcome our summer research interns here at the Seattle Science Foundation. They've joined us early this morning. So I advise them to definitely ask us questions thereafter the session if there's anything they don't understand. Again, we'll start here with a 20-year-old female. Had presented to our clinic with intractable low back pain and bilateral extremity pain for about 4 years. She is quite active. She is a college student, formerly played sports soccer, and she had noted a low back crepitus as well. Intact bladder and bowel control. She had tried conservative pain management with minimal relief. Most of the limitations was her inability to resume playing her sports due to the pain. No significant past medical history or pertinent histories is here related to surgeries or not. This is her previous treatments with respect to pain control. Here we have a lateral x-ray and AP x-ray of her lumbar spine, noting a anterior listhesis of L5 on S1. Here, there's likely concern for possible pars fractures at that 5-1, but further imaging would further evaluate this. We have an MRI, sagittal and axial views here for our students. It's a T2 sequence. Here you see some narrowing of the central canal. And severe listhesis, L5 over S1, with moderate to severe stenosis bilaterally in her foramens at L5, S1. This is a CAT scan CT of our lumbar spine axial and sagittal views. Again, noting that severe anterior listhesis at L5, S1, with significant compression of her foramens. Here we put it at a mixed grade of probably a grade 3 to 4. And here you can also note her dysplastic sacrum.
Cliff, and thank you for introducing our summer interns, and thank you for being here. Very cool to have the next generation who will take care of my back right here to learn. Who gets these isthmic spondylolisthesis, just quickly, for our summer interns? Who's at risk for those? Because they usually happen around age 11 through 13.
Yeah, children and adolescents usually typically can present with these, again, active youth. And again, they present with this isthmic spondylolisthesis, which is, again, a slip of one vertebra over the other. And they can further develop pain as they continue to grow. And the concern is, will you get further slip or not? Which can lead to further symptoms as you continue to grow older. And we'll get into, I know Dr. Elias is going to get into some of the classifications in his talk of what do you do when you're considering management for these. So I don't want to take away his thunder.
But this looks pretty dramatic. These are actually long-standing stress fractures where the back arches kind of crack and break and then slowly slip, and the patients remain very amazingly active. The classic sports are for females, gymnastics, and competitive diving, and for males, offensive linebackers, so linebackers in general. Baseball, my own son, who was a very active pitcher, had actually 2 levels of cracks. We caught them early, we were able to treat them non-surgically, and the usual treatment is non-surgical, but you have kind of a tired back is probably the most common thing, and it does not get diagnosed until patients get older. This was a former cheerleader, so she was a very successful cheerleader.
So again, now that we've had the summary of the case, being again a very young, active female, options for considering management, whether you continue pain control, observe her, see if this further progress. Do you limit her activity restrictions, Dr. Elias, or do you offer her surgical management? And if so, which approach would you consider?
Yeah, it's always nice to see you again. So there is not one correct answer for this case. I just want to start with this. What's important is to make the patient better.
Yes.
And I will talk about this in my talk. Now, if the pain, she cannot tolerate it anymore, we can offer her surgery. I'm not sure since when she started to progress, but I think eventually she will need surgery, this patient. Given the slip angle, I would do reduction and fusion, not in situ fusion. Especially that I think L5S1 is a little bit kyphosed over here. I don't have the whole parameters like the scoliosis or like the long cassette parameters.
1 second, I'll see if I can help you. I don't have a full cassette, but I do have some images related to what you had just mentioned, just for our students so that they can understand and follow what you just discussed related to slip angles. So,
It's a key thing, this patient, oh yeah, wonderful. Yeah, go ahead.
so again, this figure taken out of this orthopedics and trauma textbook discusses the slip angle, which Dr. Elias will go further into his talk. But again, it's an angle measured by the how far the L5 slips over S1, and you start at the inferior end plate of L5 and the superior end plate, crossing it with a perpendicular line along the posterior edge of the vertebra. Dr. Jean de Bousset also discussed the lumbosacral angle, which is identified here on the right in figure B as well, and discussing this for these high-grade spondylolisthesis cases.
Yeah.
And again, this is another review of some of the main classifications related to those angles and considerations for treatment. And so one thing Dr. Elias had mentioned is, again, there is concern this would further progress, and using these angle measurements, how you would consider management for these patients, and what type of procedures you would offer, and how far you would reduce. And so for our patient, her slip angle, at least at this stage, this is not a full standing films because she came from an outside institution, but right now it's at 11 degrees, and then using Dr. Dubusset's lumbosacral angle is about 26 degrees. So what would you do then, Dr. Elias?
All right. So there is also like another parameter that we should take into consideration is like the balanced versus unbalanced pelvis. I will also talk about this in my talk. Slip angle, you said it's what, 11?
Yes.
I mean, it's not that high over here. I'm not sure of your paper, what's the cutoff point for the slip angle to label it kyphotic versus non-kyphotic?
They, in their paper, they mentioned strong consideration, slip angle greater than 10 degrees.
All right, so it's like borderline. So
Yes.
Just from the X-ray itself, and I'm not sure if Dr. Chapman will agree with me, I think it's more kyphotic than a balanced one.
Yes.
So for the patient, I would reduce and fuse instead of doing just in situ fusion. And this can be done, I mean, this can be done easily from the back. I would go only from the back and we can do like a TLIF over here also, if you want, like a reduction and the cage insertion and fusion. We do not have to completely reduce back to normal X-ray, but I would just like, we should visualize when we reduce so we don't overstretch the nerves.
Excellent. In the sake of time, because we do have one more presenter, we'll show you what we did. Here's our intraoperative films. As you noted, again, we did a open and posterior incision approach from L3 to S2, exposed everything, noted the severely small dysplastic L5 lamina at that region. Again, doing a full circumferential decompression at that level, as well as you approached intradiscal osteotomy in that setting. We did place screws and did staged reductions, as again, distracting and adjusting the towers. We did a mild over reduction for which we readjusted in the case, and then ended up with this posteriorly with our post-op films. Again, this is an axial and sagittal CT scan of our L5 to S2 posterior fixation with intradiscal osteotomies at L5-1 to reduce her. I got a good result. This is her 6 months of standing films, lumbar films. So she's did quite well. We did discuss with her. So some of the concerns with these type of high-risk surgeries is trying to get enough exposure of the nerve root. If you do get any concern, there's usually about 15-20% risk of foot drop in these patients. Many of those will resolve after a few months, but you do have to advise her this, and then we'll talk about that later. Dr. Chapman?
So a couple of things. So the key questions on the spondylolisthesis are obviously the approach. And as you know, I personally prefer a posterior approach because it gives me full nerve root decompression release and a high degree of control over the vertebra to realign them. In an ideal world, I would have received or achieved more lumbosacral lordosis in her, and maybe the cage is a little bit too long. The second question is, should we fuse 4 or 5? I try not to given the young age of the patient. And you can see that she's starting to go into some kyphosis at this point in time. So at a later stage in life, I assume she'll probably need to have a fusion into 4 or 5, but we wanted to preserve maximum mobility for now. For a young female who is in her, or wants to have natural childbirth as an option, we want to be very careful that the S1 screws are not protruding into the pelvis to allow for no birthing act. And we also don't want to go to the pelvis. So we use these supplemental alar screws. We don't want to cross the SI joints to allow for pelvic ring expansion during the act of childbirthing. So those are some of the finer points. But the criticism I'd have here is the lack of lumbosacral lordosis, which I usually can get, but I somehow just probably, the cages are too long probably that I put in there. She had an actually significant radiculopathy after surgery, and we use electrodiagnostic monitoring. We actually do direct nerve root monitoring also with stim probes, and it all was very atraumatic. The nerve roots are completely loose afterwards, they're not tense. And despite that, she had a significant period of like several weeks of radiculopathy.
And I saw that here, her VMO, her vastus medialis was weak.
So she had bizarrely a lumbar plexus problem. So we did change her lumbosacral anatomy, and her lumbar plexus was more irritated than the L5 root. But I don't quite understand the physiology of that. There were no injuries in surgery, but her lumbar plexus was not doing well for a while until she adjusted. Thoughts on the topic of 4 or 5 fusion, and thoughts of going to the pelvis or having supplemental pelvic fixation?
Honestly, I thought you would do 4 to S1 instead of 5 to S2, but I think you were right in just preserving the level L4 for future. You have to take into consideration multiple variables and not only focus on the lumbar lordosis over here. So I think what you did is already like excellent results.
Yeah, she was extremely happy after going through the period of that lumbar plexopathy, for which again, I don't have an immediate answer.
Great.
Thank you, Cliff.
Thank you.
And we have one final speaker, one final case before we go to the visiting professor's lecture. This is Dr. Elias Gerstmeier. He's a research fellow from Germany. And Dr. Gerstmeier was with me in the Mazama Spine meeting, the 20th annual Mazama Spine meeting last weekend. And he was a competitive rower.
It's a fun time, yeah. So good morning, everybody. I'm presenting a female in her mid-30s. She presented to our clinic with worsening severe bilateral lower back pain that's got worsened over the last couple of 10 to 15 years. She also noted a new onset of a radiculopathy to her right lower leg and thighs. The pain is getting worse when standing and walking. She had a diagnosis of lower back scoliosis in her high school ages, but has not been received formal treatment aside from just a little bit of physiotherapy at that time. Her medical history is close to non-existing. She is a former smoker, but other than anxiety, she does not have any other comorbidities. So just on the left side, on the right side, there's a summarization of what kind of treatment she had, and you can see that the ODI score is indicating a moderate disability, but also that she has a mid-ranging pain score as well. So in her physical exams, we can observe there's no sensorimotory defects. This is her plain X-ray field, so we can see that she has a right-sided part degenerative, part dysplastic scoliosis with lumbarization of the S1 and anterior positioning, and also a dysplastic spondylolisthesis. Moving on, for the sake of time, for her CT scan. Just going to let that run through. We also find a narrowing of the S1 and S2 neuroforamen with a mild compression of the S1 nerve root on the right side and diffuse facet arthroplasty. Going to give that a second to run through.
From a personal social aspect consideration, she is I think a veterinarian I think she's a veterinarian, and she is an avid horseback rider. She's a mother of 3, but she has a horse ranch, takes care of several horses, and does all the usual chores that are associated with horsing around, such as mucking the stables, baling, that means hay transfers and stuff like that. And yes, she rides, and she has a small obstacle course on her property. This is an extremely active person with 3 younger children also. So, and she's positively crippled with her back.
Yeah, high demanding person as well. So to summarize, we have a mid-30s female with worsening severe lower back pain and now new onset of S1 radiculopathy, history of scoliosis, failed non-surgical treatment, and the image results that we just observed. So to open up the discussion, what kind of treatment would you prefer?
And can you go back to maybe that AP lateral? So this is obviously a really problematic or difficult case. There's a complex curve pattern. In the coronal plane, she has a severely hyperlordotic spine, which is, I find, always very difficult to treat. She has a rotatory subluxation at 5'1". She has a truly dysplastic spondy, so one side, the pars is elongated, but it's intact. The other side, it's cracked and broken through. So a bit of difficult constellation. She has this 4-5, again, compensatory rotatory subluxation. Thoughts, Elias, what would you say? Very active person, former smoker. She literally horses around.
I mean, this is a difficult case. I know she's only 30 and she's very active. She likes to work with horses and so on. But I would offer like a bigger construct over here compared to the cases that we saw previously, especially with this lordosis that she had. I would go like something 4 to pelvis or 3 to pelvis over here. Because you said also she has, I missed it, she has S1, you said, distribution?
Yeah, she had a radiculopathy S1 on the right side.
Yeah, and she has like rotation. I would go with a bigger construct over here. What do you think? What did you do, Dr. Chapman, over here?
So reveal?
Yeah, do the reveal, drum roll. Very good, Elias.
So he was right, spot on. We did a multi-level decompression and foraminotomy and 3-level IDOs with open reduction and reduction of the deformity and posterior fixation.
Again, we were careful. I think my S1 screws are poking through the front a little bit. She told me that she did not have more or wanted to have more children.
So at follow-up, she was had a significant pain reduction, still had a little radiculopathy, but that was on the easing side. So
she was very happy with this. So we did eccentric intradiscal osteotomy, so the deformity reduction. In a multiplanar fashion, we did a fair bit of intraoperative imaging to make sure we would try to rebalance her. Despite being on a Wilson frame, we could not get the hyperlordosis fully corrected. We made quite an effort at that. The rods are kind of even under-contoured, but we had a full release of L3 to S1, but there's only so much you can do, I think, without doing a full ventral column
Plastic
resection.
sacrum and pelvis. It's hard to correct the.
But she had a very, very nice pain reduction, and she's back horseback riding, but we did exactly what you said. We went L3 to sacrum. So,
Excellent.
thoughts?
I would do the same.
The same. Yeah, she's horseback riding again and full in practice again. So she was very happy actually. She had actually gone on pretty significant opiates also. So, any thoughts from your end? You've seen a lot of these things, and Elias is a former competitive rower. Do you put your patients in Germany on restrictions afterwards?
Well, I come from a different background, surgery-wise, so I'm educated in trauma and orthopedic surgery. And it's always hard to restrict people after surgery. And this is still an ongoing debate in proximal humerus fractures about complications and movement restrictions and postoperative frozen shoulders. So I think when we perform something and we do a proper surgery, patients will benefit the most if you can allow some sort of movement and a more aggressive postoperative regime, rather than being very restrictive about your movement. But there's always the possibility of various complications, loosening, non-union, delayed union. So it's always a balance act.
Dr. Chapman, when do you tell them they can go back to sports activities?
Usually at 3 months.
3 months.
Again, we limited the amount of surgery. She had been to other doctors before who wanted to do a full T10 to pelvis fusion because of her scoliosis, and my interpretation was that she had an antalgic component to mechanical component. She had this bizarre rotatory subluxation of L5 on S1 through a unilateral pars defect and dysplastic elongation of the contralateral pars. So my theory was that by us kind of getting L5 stabilized and somewhat realigned on S1, we could help her. Doing a bigger sacral dome osteotomy was one of my contemplations, but I would have had to go to the pelvis. I did not want to fuse it to the pelvis at this point in time, but that's an arguable technical point that I would possibly do in retrospect differently. She did not have any neurologic problems afterwards. She was actually almost immediately relieved, and I used the L3 vertebra as a reference in terms of the coronal plane. So as long as I could get that realigned, that's better. But for me, having L3 horizontal would have been the alignment goal, and I did not quite get that. So yes, so Dr. Ahmed Najjar, and I want to thank all of our friends from around the world. Said, can she go back to sport? Absolutely. This is the whole goal, and again, within reason, if she did something absolutely crazy, but again, I have no doubt that she'll probably wear down her L2-3 segment at some point in time, because she's the kind of a person, she will muck the stables and bale the hay without a question. That's not an option.
With her active lifestyle, she's very prone towards having further complications in a proximal junctional kyphosis and probably failure. But this is something we have to discuss over time.
And so then the question by our good friend Maximino Telesguis, thank you again for your loyal viewership. These are Ehler screws, so these are not iliac screws. But if you look very carefully, the right-sided screw is right along the SI joint. And so is this a cause of SI joint arthritis? I don't know is the honest answer. Ideally, I would have had it a little bit shorter, like on the left side. But these are supplemental screws mechanically, so they're by far not as strong as iliac screws. And I've just not seen that to be a very major propagating factor. In principle, the SI joints are a little bit more forgiving. They're a amphiarthrosis, so it's the anatomic determination. So they're not a true synovial moving joint. They're more a fibrous cartilage layer clad kind of a articulation. So they don't act like a knee joint. If you had a screw like that in the knee joint, it would blow out very rapidly, it would cause chondrolysis. We don't see a chondrolysis like that in the SI joints usually, but the proof will be there in 2 years from now. So far, so good. And again, we did not fuse her to the ilium because of her theoretically still being in a birthing age, although she told me she, as I said earlier, would not want to have more children.
Yeah.
But thanks
I
for
mean,
your questions,
also
guys.
post-operatively, up to now in that follow-up, she didn't have pain in that region, so.
Yeah, so far no pain there, but again, to be continued. But if there's an incidental partial violation of the SI joint, I don't see that as a big pain generator or propagator of disproportionate SI joint arthritis. Great, thank you, Elias. So great honor for me to introduce our guest speaker today, our professor of neurological surgery and chief of spine at the Dallas Veterans Administration Hospital System, Dr. Elias. He is a former fellow here at the Swedish Neuroscience Institute. I'll get the conflict out right away. He also trained at the University of Virginia, and he originally trained at the American University of Beirut in Lebanon. He is a absolutely wonderful colleague and a critical mind. We just recently saw him at the Global Spine Congress in Bangkok, and he gave several very well-attended and thought-of lectures. We really enjoy his thoughtful approaches. His wife is a well-known epidemiologist also, so there's a certain amount of brain trust in that family household. I can only imagine what the dinner conversations go about. Elias has had some great publications, such as on the extensor spinae block from a surgeon's perspective, and with that, he's popularized this very interesting new technique in our spine surgery circles more. As always, it's important that we cross silos across the various specialties and open our eyes towards others. So Elias is going to talk about spondylolisthesis and give us a little historical reflection on this interesting anatomic and biomechanical, architectural, as well as neurologic problem. Thank you for being here this morning from Dallas, Texas, and look forward to your presentation.
Thank you, Dr. Chapman, for this opportunity. I'm just trying to. All right. Again, thank you for this opportunity. It's always nice to present at SSF. It brings memories back. All right. Can you see my slides?
Yes.
All right. So today I will be presenting about high-grade spondy. This is a topic that's a little bit controversial due to the lack of like good publication and good guidelines. So we'll just start with the definition. Spondy or spondylolisthesis, it can be divided into high grade and low grade. High grade is anything that's translated more than 50%. Low grade is anything that's less than 50%. The term was initially coined by an OBGYN, Dr. Killian, back in 1854. And why OBGYN? It's because they found out that whenever a patient had high-grade spondy, it caused a difficult labor. Classification used generally for spondy is the Myerding classification and goes from grade 1 to grade 5. Grade 5 is the spondyloptosis, or the L5 is completely in front of the S1. It's jumped completely in front of the S1. Types of the spondylolisthesis were defined by Dr. Wilsey, and they can be categorized into dysplastic, isthmic, degen, traumatic, pathological, or iatrogenic, or post-surgical. Mainly patients who have spondy, they present with back pain, axial pain. They can also present with radicular pain. They can have sensory deficit, foot drop, or progression of deformity. In terms of planning for the surgical intervention, the big two plans are either to do in situ fusion or to reduce and fuse, or reduction. So it's either reduction or in situ fusion. For reduction, we have the option of TLIF plus or minus dome osteotomy. We have ALIF going from the front. We can do the gains, which is a very difficult technique to do, which is the L5 vertebrectomy, or just a posterolateral fusion. For the in situ fusion, There are the Bowman's technique, the modified Bowman's, or what my previous mentor described, Bob Hart, the modified Bowman. We have the reverse Bowman and also the posterolateral fusion. Each technique comes with its complications. The reduction technique usually takes longer surgical time, more blood loss, and iatrogenic L5 injury, nerve injury. Whereas the in situ fusion, it comes more with non-union or slip progression. What if we do not surgically treat a patient with high-grade spondy? We don't know the real answer. There is only one paper about this, and it's published back in 1987. So the real answer is we don't know. If we don't treat those patients, what will happen? Now, in terms of surgical planning, we should take into consideration multiple factors, and there is no straightforward answer to what to do next. We should take into consideration the dysplastic features of the spondy. Is it low or high dysplastic? Does it have a sacral dome? Should we do a sacral dome osteotomy, yes or no? Do we have a room for cage, or we don't have a room for the cage? We also should take into consideration the spinopelvic parameters, alignment, mismatch, should we reduce or not reduce? And when we decide to reduce, we should take into consideration the nerve stretch. Now, for the dysplastic features, every high-grade spondy can come with either low or high-grade or high dysplastic feature. When we say low dysplastic, it means whenever we have like a regular L5-shaped vertebra, when we do not have a sacral doming, when we have intact posterior elements like no spina bifida, and when we have normal TPs. Whereas when we say high dysplastic features is when it's trapezoidal in shape, when we have sacral doming, and we have dysplastic posterior elements, and sometimes we have small TPs. This is an example of a dysplastic case of high-grade spondy. I put it here just to show you the trapezoidal shape of the vertebral body and the sacral dome. Now, we all know the pelvic parameters, the PT, PI, and SS. We use them for scoliosis cases. But as my colleague Pierre mentioned before, there is like one extra variable that we should take into consideration, which is the slip angle. And slip angle is usually formed by a line drawn parallel to the inferior aspect of L5, and it intersects with the line of the posterior aspect of S1. And usually this slip angle is taken into consideration as a sensitive indicator for a slip progression and whether we should fuse, which we should reduce or not. Now, the other counterpart of the slip angle is the Dubois lumbosacral angle, which is basically the same in terms of taking the posterior line of S1, but instead of taking the inferior L5 line, we take the superior end plate of L5. Another variable that we should take into consideration is the balanced versus the unbalanced pelvis. So also each high-grade spondy, it can, as we said, it can be high dysplastic, low dysplastic. It can also be balanced and unbalanced. And when we say balanced pelvis, it's when the patients have low PT and high sacral slope, whereas the unbalanced pelvic version is when you have high PT and low sacral slope. And this will also help us in planning the surgery. And this paper found out that patients, when they have unbalanced pelvis, they will benefit more from reduction, whereas when they have a balanced pelvis, they will benefit more from in situ fusion. We should also think or take into consideration when we fuse where to stop. So where should we stop? Is it over L4, L5, or even L3? And for LIV, where should we stop? Is it S1, or should we take into consideration also the pelvis? I will talk a little bit about the evolution of the in situ fusion. First concept of the in situ fusion was with Kapner. That was back in 1932. I think he only did a concept design of the surgery. He did not operate. Then Dr. Speed, back in 1938, he described an anterior approach for high-grade spondy, where he used a fibular strut, and he went anteriorly from L5 to S1. On the, on the right side, it's his surgery. On the left side, it's a cadaver that he showed. This was followed by Dr. Bollman in 1982. He published two papers, one in 1982 and in 1990, where he described coming from the back, doing an in situ fusion and using a fibular strut. And what he did is something similar to this described by Dr. Vaccaro, which is going from the back, doing LAMI decompression, and inserting a fibular strut. This was described by Darrell, also the evolution. So instead of only using fibular strut, they used the pedicle screws. And Dr. Sasso also used bilateral two fibular strut with pedicle screws. So complications of fibular graft are usually pseudoarthrosis, slip progression, and the graft failure itself. And so surgeons started to look for other alternatives for the fibular graft. And so Abdu, back in 1994, he used a transsacral transvertebral screw going directly from the sacrum to the L5 vertebral body. This was also used by Grob in 1996 and by Francois from Belgium later on in 2005. Still, when they replaced the fibular graft with the transdiscal screw, they had pseudoarthrosis, they had hardware failure and fatigue, as you can see on the X-ray shown here. So they searched also for other alternatives, and instead of using a fibular graft, they used a cage. So Slozar back in 2001 used a titanium cage going from the back, and he used also bilateral posterior pedicle screws. Bartolozzi, back in 2003, used also the same concept. He used cage going all the way from the back, from S1 going through L5, and used also pedicle screws. And then Dr. Bauhart, one of my mentors in Swedish, he used the modified Bollman technique. So he used both screws and the titanium cage going all the way from the posterior from S1 to L5. Other techniques are the reverse Bollman or modified speed, which was described again back in 1938, but instead of using fibular graft like here, they started using titanium cages. Now, for the reduction techniques, as Dr. Chapman mentioned, we have the TLIF technique, regular TLIF technique. And then for the high dysplastic, we have the TLIF plus sacral dome osteotomy. And you can also do ALIF going all the way anterior. And there is the complete vertebrectomy, which is described by Dr. Gaines. He has a paper where he described, I think, 30 cases or so, where he completely removed the L5 vertebra and he reduces the L4 over S1. Now, we have to keep in mind that whenever we reduce, there is a possibility of nerve stretch, and the patient might wake up with L5 nerve deficit. There are multiple cadaveric studies that try to study how much we can do as nerve stretch, and I couldn't find like a definite answer or number, but what I found out is the reduction and tension are not linear. So you reach certain length in when you reduce, where you directly start to lose the function of the L5 nerve root. Now I will present a case that I did a few months ago. This is a 67 male, BMI 32, hypertensive, dyslipidemic. He has chronic back pain of more than 30 years. He told me that this is a military injury when he was back in the army. He has progressive worsening over the last 10 years. Back pain is unbearable anymore. He described it as 8/10, sometimes 10/10. And he has on-off right posterior thigh and calf radiculopathy. His exam, motor power was intact in general. His X-rays, extension, flexion are as follows. We have some movement here. The slip angle is 5. So Pierre mentioned the slip angle with the cutoff point of 10. So this is an acceptable slip angle, and PT is 35, SAS is 49. This is his scoli X-ray. So in general, he's well aligned over here. SVA is neutral. This is his MRI. This is L4/L5 here. It's not completely compressed or foramen are clearly patent bilaterally, but over L5S1, here you can see how much he has stenosis both over the cord and over the foramens. And this is his CT scan. So what I did is the following. Dr. Chapman, do you want me to jump on what I did, or you want to discuss anything?
Sure, I'm happy to talk about that. So this is a great case. The first thing that I see in patients like this is I see atherosclerosis in their arteries, and my suspicion immediately is raised that they have not optimized themselves. So before I jump into any surgery, I would heavily question the patient about nicotine use, reasonably healthy lifestyle options, daily low-intensity aerobics, i.e. a recumbent stationary bicycle. Our poor scribes know that I tell that to about everybody, because what I frequently see is that patients feel disabled, don't do anything anymore, fall into this negative vortex trap of inactivity and become more and more deconditioned. Also, high suspicion of index of suspicion of nicotine abuse, possible alcohol use. So these adjuvant lifestyle factors reflect in the spine. If I can impart one thing on our young summer interns, it is that our spine is like a filter of life and retains all these kind of vices somewhere in it structurally or in the soft tissues. And the spine is a very prime source. It's actually probably the prime source of disability in human beings. So it's a really big deal to kind of remember that the spine is, and here's the theme, a filter of life. I'll get off my bandstand. After I've optimized these things, what I don't like is the severe chondrolysis that took place at L5S1. This is an angry kind of a joint destruction. I do think that this patient will absolutely need surgery. I hate to say absolute, but this chondrolysis pattern that's shown in that CT scan is pretty profound, and it's not expected. So this is not the normal kind of a cartilage degeneration process. As you know, I personally prefer an L5 to S2 probably fixation and reduction. I debride this chondrolytic material, especially around the L5 root. I'd counsel them about a 10 to 15% risk of at least temporary L5 root palsy. I would do my very best to fully decompress it, protect it, avoid stretching the nerve. But this is an incomplete science because we still don't fully understand L5 palsies. I have not made up my mind about going to L4 in this patient. I would give him his calcifications, do a arterial duplex exam to make sure there's not a hidden femoral bifurcation pathology. And I have not made up my mind about L4 or 5 inclusion or not. I would try to avoid it, but I can't totally say no to L4. I would get it onto my consent. So these are my thoughts.
All right. So you would go from L5 to S1, or?
I would S2. I always nowadays go to S2, especially the upper end plate of S1 is compromised here. As you've identified, this is a dysplastic sacrum now, so the anterior horn of the sacrum, the promontorium, has been eroded. There's a trapezoid L5 vertebra, so the L5 itself has subsided mechanically into the S1. So I would absolutely go to S2 or the pelvis in this patient. This is a male, so going to the pelvis is not the end of the world. But definitely some supplemental fixation to S1 alone, because I would be highly worried about S1 screws loosening or there being a sacral fracture. And again, I did not see the L5 pedicle height in these trapezoid vertebrae. The L5 pedicles can actually be eroded by, yes, nerves are stronger than bone. The L5 roots can actually over time erode these pedicles and make them pencil thin and unsuitable for pedicle screw fixation. So I'd, without a question, get a consent for possible L4 fusion. As I said, I can't make up my mind at this point in time. I'd get it on the consent as an option, but I try to avoid it.
And would you reduce here, or you would not?
Absolutely, absolutely. I try to reduce it. You said it earlier. You said it very nicely. I try to optimize the alignment, get some reduction going, but less than the translational reduction. I'd like to get the angle up. I'd like to set L5 straighter onto S1 if at all possible.
All right, even with the slip angle of 5?
Yeah, for me, again, this is the interesting thing about the slip angle. You did a beautiful job lining up the main things. I mean, the patient clearly has a hyperlordotic lumbar spine, lumbar lordosis of 67 degrees, so he's somewhere compensating, and I'd like to try to get rid of that hyperlordosis somewhat.
All right. All right, I did a slightly different approach from Dr. Chapman. So I did the modified Bowman over here, and I will show it to you. So I started with going, so I did an in situ fusion, and what I did is a transsacral transvertebral screw from S1 to L5, and I did a pedicle screw over L4. And after I did the screws in, I did the complete decompression over L5 S1, and I did the foraminotomies. And let me see. And then I went and I decompressed the S1 lami over here to expose the S1 and S2 nerve roots. And I used the cage mesh over here. So I used the pedicle finder to create the trajectory from S1 to L5. And then I used the ACL reamers. And I used 2 ACL reamers just to make sure I'm not pushing the L5 over S1. And then I inserted a mesh cage and I put biologics in it. So what I ended up doing is a modified Bowman. And I ended up doing this. What are your thoughts, Dr. Chapman?
So I used to do these Bowman grafts, and I applaud you. This looks very nice. This is a very good technique to have in your armamentarium. What I don't like about it is over time, and I think you put a better cage in than what we had available. I've had these cages fail. I started doing this many years ago with fibula allografts. And if you look at the mechanics of this, there's a clear shear factor that goes straight, kind of literally perpendicularly through that cage. So I've seen fibulas break. So I used titanium mesh cages like what you did with ACL reamers between the S1-2 interval. And then they would start shearing. They did well for a couple of years. You did something very important here. You put the Bill Abdu's supplemental transsacral screws in there as well. So there's probably an extra mechanical support that you provided that in my era I did not do. But I think it's an important thing to do, and we should not just be fixated on reducing these spondies, as tempting as it is. My main failure point here in this patient is 4 or 5. Again, this is relying on a posterior fusion. You probably did a lot of posterolateral fusion in there, so hopefully this will heal. But in a healing impaired patient, I'd be worried that you'd need a cage in there or something to do that. So great technique. You can't distract you can't retract the cauda equina past the midline, and you have to obviously be careful of manipulating inside the axilla of the roots to avoid stretch injuries. But it was a cool video that you had, so thanks for sharing that. Looks beautiful.
Thank you. So post-op patient had 1 or 2/10. Post-op day 1, he was able to ambulate without brace. and he was discharged post-op day 3. He didn't have any neurological worsening. Unfortunately, I do not have follow-up X-rays on him. Whenever I call him to come and get new X-rays, he tells me that he's fine. He does not want to get new X-rays. In conclusion, there are no guidelines for treatment of high-grade spondy. Optimal technique remains controversial. Multiple factors should be taken into consideration for reduction versus in situ fusion. And the final aim, or our aim, is to make the patient feel better and not to harm him or harm the patient post-op. Thank you.
Thank you. So if you can go back again, I don't know whether you can do a video still. So one of the key things yet intraoperatively, so if you can stop it, one of the key things is the L5 root decompression. So these patients, it always amazes me that they don't have more preoperative neurologic symptoms. They come with buttock pain. I think that this is an L5 root pathology from their primary motor ramus, which goes into gluteus medius. But how far do you suggest decompressing the L5 root? Do you want to take it past the DRG? I've seen many people in the past, when I was raised as a young surgeon, just kind of get to the offspring of the root and stop. As you know, I like to go way on the side of the L5 roots towards the anterior, or towards the superior part of the sacral ala, actually, so that it's completely released. But I've always been amazed how compressed that nerve is. So what are your thoughts about L5 root decompression? How much should we emphasize a wide and far decompression of L5?
Well, I do the same as you do, Dr. Chapman. I always decompress all the way out. I do not do like partial decompression. And especially when you have high-grade spondy, I tell the patients, you have 20 to 30% risk of transient nerve injury that then you can go back to normal later on, and you have 5 to 10% of permanent L5 nerve injury. So I still, despite those numbers, I still do like full decompression of the nerve roots.
Yeah, so go over those numbers again, because I think that this is one of the important things. We have to tell patients about this. We should document it very carefully. What are the numbers one more time? What's temporary and what's permanent nerve pathology?
So I tell them you have 20 to 30% of transient neuropathy and 5 up to sometimes 10% of permanent nerve injury. They need to understand like what are the risks and benefits of this surgery, especially with high-grade spondy before going to surgery.
I think those are very important numbers, and I hope all of our younger colleagues who are practicing in the field should know those. Those are exactly the same numbers that I noticed. Why is the L5 root so vulnerable? I mean, you and I have the same philosophy. We should decompress that nerve. We baby that nerve. We don't cowboy around. We don't do anything radical or herky-jerky kind of. But what's different about that L5 root that is so susceptible to a drop foot, which is, or abductor lurch? Why is it so exposed and vulnerable?
I mean, are you like asking in general or with high-grade spondy? Because high-grade spondy, I think compression from, like, it's whenever it's high-grade and the slip, it's acting like a disc compressing the nerve roots. So it's like a pseudo disc. Also, another factor is low vascular supply from all the compressed area, like narrow area. And sometimes the pars fracture will contribute to this. So I think very minimal vascular supply. And on top of that, stretching will put the L5 nerve root at high risk of nerve injury.
So I think those are all very good points. With Shane Tubbs, the famous neuroanatomist who worked here for 2 years, we did some studies, cadaveric studies, and we looked at cadavers who had a high versus a low foraminal height, and we then measured, Shane Tubbs and some of his teams and members of the SSF community here, measured the quantity of neurons in L5 dorsal root ganglia, and it was an amazing difference. Those who had a very low foraminal height had like a quarter of the neurons in the DRG compared to the others. This is published in the Journal of Neuroanatomy. So if you have a normal foraminal height, you have far more redundancy. And as you said, a chronic compression on the body's part is responded to by denervation. Basically, it loses its neurons, and we're still functional. The functional threshold, however, becomes narrower and narrower and lower, and at some point in time, there's just no neuronal reserve. If you then do anything in that area, it can very likely lead to a functional loss, and there's also no redundancy in terms of extra circuitry powering the dorsiflexors or the gluteus medius. So it's a very exposed nerve in terms of functional deficits. So that's a very important thing. Neuromonitoring, do you use that? Do you use, I mean, I've again even gone to the desperate measure of neural probing, so putting on a neural probe and measuring impedance of the nerve during and after reductions. I'm not sure it helped me one bit, but it makes me feel better. Do you use anything? Do you have any tips and tricks? Do you use motors for these?
I do use motors, but I do not use, I mean, I do not heavily rely on neuromonitoring. I think it's better to visualize the nerve stretch. This is, I think, one of the most important factors. I didn't have good experience with neuromonitoring, especially whenever we lose like signals. And you like I mean, you know it, sometimes you lose the signal and you don't have any explanation. I don't know, do you use like visual help for like stretching the nerve? Like when do you stop stretching the nerve?
Absolutely. So we use probably very similar numbers, but the main thing is avoiding a nerve stretch. So the nerve has to have about 3 millimeters of easy play. So I use a small blunt nerve hook and probe the axilla of the nerve and make sure that the nerve is not stretched. So that's a really big deal. And Dr. Cliff Pierre is so kind. He's so cool how he puts publications for our viewership. You can actually see the reference that he talked about. There are 2 or 3 different papers we put out. One was with Cliff Pierre also as a co-author, where we looked at how the L5 nerve moves when we do a reduction of the deformity. And Dr. Kulkarni, thank you for your reference also. So L5 root is very exposed and a problem, and not a good thing to do. And Dr. Kulkarni, thank you for your paper also, Novel Technique of Reduction of Spondyloliptosis, Minimal Access Surgery, a case report, where we see how you did this. And again, this is still one of those subject areas. I'm still in favor of a posterior midline exposure because it allows me to visualize both nerves very cleanly, but I respect the efforts of our colleagues with less invasive techniques to try to achieve an improved alignment. With this, we'll come to a close. I wish you all a happy and safe 4th of July, and for those who can take Friday off here in the US, a prolonged weekend. Elias, so good to see you. Great topic, beautiful slides, very factual. So please claim your CME credits, and please know that we have the master's course coming up in the very near future, which is a highlight. It's a unique course. It's actually not a course. We have an amazing faculty coming together. I don't want to do any injustice to anybody by omitting somebody, but it's literally a who's who of North American spine surgery, including Vincent Arlet, Chris Shaffrey, Steve Glassman, John Dymar. I mean, there's so many great names and minds, and they all will talk about something unique. They'll talk about what they like and are passionate about most, and they'll show their tips and tricks in the OR. So please tune in or please join us live at our master's course, which is coming back in the near future, and I'll ask Corey to Alexis to put that into the box. So register for that, and it's coming up next weekend, as I believe, the 12th annual Spine Masters course, July 13th, here at the SSF facilities. With that, we'll sign off. Elias, good to see you. Stay in touch. Great work. Take care. Thank you all. Welcome here.